and no evidence of new parenchymal disease, but her PA was noted to measure greater than 4.5 centimeters. So she then underwent a CTA of her coronary arteries to assess her for left main coronary compression syndrome, which patients with PAH and large PAs are at risk for, but she had no evidence of this as well. And then finally, she underwent submaximum cardiopulmonary exercise testing in our clinic, which most of our patients do, which suggested an abnormal pulmonary vascular response to exercise, suggested by breathing inefficiency, impaired dynamic pulmonary perfusion, and systemic oxygen desaturation with exercise. So taken together, we were worried that her PAH was progressing, and we weren't yet sure why. But we also needed to rule out the development of other things like high output heart failure, which these patients are at risk for in the setting of significant systemic vasodilation. So she underwent a right heart catheterization. For context, I've included her initial right heart cath prior to initiating therapy, which had shown severe precapillary pulmonary hypertension with a depressed cardiac index with a mean PA of 60 millimeters of mercury, a pulmonary capillary wedge pressure of 8 millimeters of mercury, a PVR of nearly 16 Woods units, and a cardiac index of 1.9. Now, following treatment with maximal therapy, her right heart cath revealed a near systemic PA pressure of 101/44 millimeters of mercury, a wedge of 14 millimeters of mercury, and a PVR of nearly 12, interestingly, with a preserved cardiac index of 2.8. The preserved cardiac index and low proBNP in light of her profoundly abnormal hemodynamics was interesting, but not something uncommonly encountered in women with PAH, who when compared to men tend to have more profound vascular remodeling, but with better RV adaptation. So in summary, our patient had progression of her PAH despite treatment with maximal therapy, which was unusual in a patient without, for instance, connective tissue disease. And so we did revisit her case overall. This led to the uncovering of a bone morphogenic protein receptor type 2, or BMPR2 germline mutation, which is recognized in up to 25% in patients with idiopathic PAH. Importantly, these patients are shown to have an increased risk of death or transplantation and have a higher all-cause mortality when compared to non-mutation patients. So perhaps this is why she was progressing despite treatment. But regardless, our main question was, what else could we offer our patient to improve her symptoms of right heart circulatory system failure, to improve her quality of life, but more importantly, to decrease her risk of dying from this disease? So let's take a step back and discuss some basic facts about PAH. So PAH is characterized as group 1 PH. It's a heterogeneous disease with diverse etiologies. It can be idiopathic or caused by genetic mutations or by drugs or toxins. It's associated with connective tissue disease and congenital heart disease, HIV, schistosomiasis, and portal hypertension. And disease manifestations are both associated with the PAH subtype and age, sex, and the comorbidities of the patient. PAH is a rare disease. Its incidence and prevalence are 6 and about 50 cases per million, respectively. Most registries report a greater proportion of women with PAH, but we know that male sex is independently associated with worse survival. So there are sex-specific differences in PAH, but these are incompletely understood. And interestingly, there's been a recent age drift in idiopathic PAH. Traditionally, it's thought of as a disease affecting young to middle-aged people, but recent data show a substantial increase in the average age of newly diagnosed PAH patients. For instance, the French and American registries both report enrollment of individuals with an average age of around 50 plus or minus 15 years. And these patients behave differently than our younger patients, in part because they have a greater degree of comorbidities like diabetes, hypertension, and COPD, which impacts both their symptom burden and the way that we can treat them, especially given that treatment hasn't been studied directly in this group of patients. And PAH is an incurable, life-threatening, and life-limiting disease, and lung transplantation remains the only option for end-stage disease. But modern treatment has really revolutionized the outcomes for these patients. before effective therapy, median survival for newly diagnosed patients was only about 2 years. And now the median survival is reaching 7 years after diagnosis, which is better, but certainly we can probably do better. Regarding diagnosis, a multi-step approach to diagnosis should be considered in patients. And patients generally present with subtle and nonspecific symptoms, the most common of which are dyspnea, fatigue, weakness, lightheadedness, and near syncope. Patients are likely to be seen first by internists for these symptoms, and the initial evaluation should include a comprehensive physical, history, ECG, and labs like a proBNP, which hopefully raises suspicion for PH or cardiac disease, which should prompt an echocardiogram or cardiopulmonary exercise test, which can help elevate diagnostic suspicion. And once patients are felt to have an intermediate or high probability of PH, they should be referred to a PH center for further evaluation. And importantly, there's often a significant delay in diagnosis, so a high index of suspicion for the disease should be had, especially in patients with risk factors like a family history or underlying connective tissue disease. And of note, despite efforts to improve early identification of PH, the mean delay in diagnosis still ranges from 2.5 to 4 years and doesn't seem to have improved since the development of the NIH PH registry in the 1980s. Right heart catheterization is the gold standard for diagnosis and classification of PH. And this is a complete list of the cardiopulmonary hemodynamics that must be measured or calculated during a test. And vasoreactivity testing to identify acute vasoresponders who may be candidates for treatment with high-dose calcium channel blockers should be completed in patients, especially those with idiopathic PAH, heritable PAH, or drug-induced PAH. Here we used inhaled nitric oxide for this testing, but inhaled iloprost can be used as well. A new hemodynamic definition of PAH was described in the 2022 European guidelines. The mean PA cutoff was decreased from 25 millimeters of mercury to 20 millimeters of mercury, and PVR was reduced from 3 Woods units to 2 Woods units. This was based on data from normal subjects across different age ranges. And the pulmonary capillary wedge pressure cutoff remains less than or equal to 15 millimeters of mercury, even though we know that upper limits of normal is probably closer to 12 millimeters of mercury. And as you can see in the diagram, PAH is considered a precapillary form of PH, and it theoretically only affects the pulmonary vasculature prior to the capillary connection to the left heart circulation. But this is likely reductive as there is accumulating evidence supporting the involvement of post-capillary venous vasculature in all PH groups with varying degrees of intensity. PH is characterized by occlusion and remodeling of the small peripheral lung vessels that leads to a rise in pulmonary vascular resistance and mean pulmonary artery pressure, which results in right heart dysfunction. And one last point about PAH that I wanted to make is that it's a systemic disease, and we don't really think about it often that way. It's associated with impaired LV function, renal dysfunction, neurohormonal overactivation, skeletal muscle dysfunction, congestive hepatopathy, and metabolic dysfunction as well. Increased PVR related to vessel remodeling is the hallmark of PAH pathophysiology because its impact on right heart afterload. There is a complex relationship between afterload contractility and RV remodeling. Ideally, an increase in RV afterload, which is seen on the left hand of the screen, which is determined by the PVR and the pulsatile load, should be balanced by an increase in contractility, seen on the right side of the screen, which is determined by inotropy and compensatory hypertrophy. When there is an imbalance, the result is RV-PA uncoupling, reduced RV function, and RV dilation, which causes enlargement of the tricuspid annulus and tricuspid regurgitation, and a deleterious cycle leading to more dilation and dysfunction of the RV. This is sometimes described as the RV death cycle, a term that you are all probably familiar with. What we try to do in the setting of PAH is to use medications to attempt to decrease RV afterload in order to try to restore RV dimensions and therefore its systolic function. This is what we call reverse RV remodeling, or a return to normal. And this is a concept I'll come back to throughout this talk, first related to the RV, and later related to the pulmonary vasculature. In terms of the mechanism of PAH vasculopathy, dysfunctional pulmonary endothelium plays a large role. There's impaired balance between vasoconstrictors and vasodilators. There's upregulation of prothrombotic signaling, dysregulated metabolism, and increased expression of cellular adhesion molecules like E-selectin, intracellular adhesion molecule 1. And there's increased pro-inflammatory signaling, such as unregulated release of chemokines and cytokines and growth factors. Triggers that have been recognized as causing pulmonary endothelial cell dysfunction in PAH include endothelial cell death, plus an increase in contact and flow-derived stresses, such as fluid flow-induced shear stress within the pulmonary vasculature, and excessive production of reactive oxygen species, toxins, and inflammatory mediators. PAH vessels also have dysfunctional smooth muscle. These cells have an increased ability to migrate, proliferate, and survive, and they have impaired apoptosis. And there's a lot of immune dysregulation that's been shown in this disease process with persistent inflammation and the perivascular cell infiltration of CD4 and CD8 cells, B lymphocytes, natural killer cells, neutrophils, macrophages, and mast cells. There are a number of genetic and epigenetic drivers of PAH-related vasculopathy and right heart dysfunction. For instance, the most important or relevant genetic drivers to this date seem to be variants in BMPR2, a member of the TGF-beta superfamily, which are present in up to 80% of patients with heritable PAH, and as we heard earlier during our case vignette, in up to 25% of patients with sporadic PAH. Regarding epigenetic drivers, just one example is that hypermethylation of the BMPR2 promoter to inhibit BMPR2 expression has been reported in patients with PAH. And I'll note here the complex role of molecular mechanisms in RV dysfunction, but that deserves its own grand rounds. As discussed previously, the hallmark of PAH is the excessive hemodynamic load in the RV that causes progressive RV dilation, dysfunction, and failure, the latter of which is characterized by symptoms related to low cardiac output and systemic congestion. RV function, in fact, is the key determinant of symptoms and survival in PAH. The classic therapeutic approach consists of general measures to reduce the risk of right heart decompensation, symptomatic treatments like diuretics, and finally, targeted therapies to reduce RV afterload by reducing pulmonary vascular resistance. And classic PAH therapies seek to restore balance of vasoconstriction and vasodilation in the pulmonary endothelial and vascular smooth muscle cells. And as seen in this diagram, PAH medications include 3 classes of medications that act on different pathways, which seek to restore this delicate vascular balance. You have the endothelin receptor antagonists like ambrisentan and macitentan, which promote vasodilation through accelerated production of prostacyclin and NO and clearance of endothelin 1. You have the phosphodiesterase type 5 inhibitors like sildenafil, which have vasodilating actions on arterial smooth muscle cells. The soluble guanylate cyclase stimulators like riociguat, which has direct vasodilatory effects by inducing cyclic GMP production independently of endogenous NO production. Your prostacyclin analogs, which includes IV, sub-Q, inhaled, and oral medications, and contains the only drug, epoprostenol, to have shown an increase in survival compared with standard therapy in a randomized controlled trial published in 1996. And you have your oral prostacyclin receptor agonists like selexipag. Hemodynamically, these medications, when used alone or preferably in synergy with other medications, have been shown to cause a decrease in pulmonary vascular resistance, mostly produced by an increase in cardiac output and only a modest reduction in mean pulmonary artery pressure. And that's important because cardiac output and stroke volume in particular are determinants of survival in PAH, while mean pulmonary artery pressure is not. And I'll just note here briefly that all the previous trials supporting the use of these therapies that we've just talked about were done using the pre-2022 definition of PAH, where the mean pulmonary artery pressure was cutoff was still 25, and the PVR cutoff was still 3, and thus evidence supporting the efficacies of these drugs in patients with mild hemodynamic abnormalities is sparse, and more data are needed to determine if treatment with these drugs are going to be beneficial in that population. So here I bring up this question about whether traditional PAH medications are disease modifying, because there's a lot of discussion in the field right now about which PH medications deserve this designation. And I think the short answer to this question is probably yes, and that disease modification likely exists on a spectrum of what drugs can accomplish. To be disease modifying, a medication should change the course of a disease. It shouldn't just improve symptoms, but also improve markers of disease severity, reduce the risk of clinical worsening, improve survival, potentially even cure the disease. And it should also change the underlying pathology and pathophysiology of the disease itself. We often think about pulmonary vasodilators as mere dilators of the pulmonary vessels that help to remodel the right heart, but not as pulmonary vessel remodelers themselves, but this is probably too reductive. As just a few examples, we know from early work on the PDE5 inhibitors that sildenafil produces substantial inhibition of platelet-derived growth factor stimulated cell proliferation and DNA synthesis. Additionally, this graphic is from an interesting study that looked at the effects of macitentan on pulmonary vascular remodeling in a hypoxia model of PAH, a rat model of PAH, and found that macitentan-treated rats exhibited less remodeling of the distal PA and experienced increases in perfusion and microvessel density within the lung, pointing to treatment of the underlying vascular pathology as opposed to simple vasodilation. With that said, how do we think about treating patients? In newly diagnosed PAH patients without significant comorbidities, the treatment algorithm per the guidelines is based on a comprehensive multi-parameter risk assessment, seen on the top half of the screen. That's the 3-strata model of 1-year mortality risk to characterize patients as low risk, intermediate, or high risk. And as you can see, high risk disease confers a greater than 20% mortality at 1 year. So these are really sick patients. The assessment is based on clinical variables such as functional class, 6-minute walk distance, CPET variables, echocardiographic parameters of RV function, and right heart hemodynamics. On the bottom half of the page, I included the 4-strata risk assessment tool that's based on refined cutoffs of a smaller number of variables that has been shown to be more sensitive to changes from baseline and has better discrimination between the intermediate risk group, which helps to guide therapeutic decision-making. So the 3-strata model on top is recommended to be used during the initial diagnosis of patients, and the 4-strata model is recommended to be used during follow-up. And so available data support a risk-based, goal-oriented treatment approach based on achieving or maintaining a low-risk clinical status, as these patients have been shown to have better survival. And within the framework, the goals of treatment include proactive and aggressive upfront treatment that targets multiple pathways of pulmonary vasodilation, symptom relief and the achievement of a better functional class, the delaying of disease progression, the avoidance of hospitalization, achieving reverse RV remodeling, and ideally improve survival. In terms of medication selection, for simplicity, I'm focusing on patients without cardiopulmonary comorbidities who are non-vasoreactive, and that's to the left of the algorithm that you see on the screen. For patients at low or intermediate risk, initial therapy with an ERA and PDE5 is recommended. And this approach was assessed in the landmark AMBITION trial, which compared initial combination therapy with tadalafil and ambrisentan versus monotherapy in patients with functional class 2 or 3 symptoms. And the primary endpoint in this trial, importantly, was time to first clinical failure event, which is a composite of death, hospitalization, disease progression, or an unsatisfying or unsatisfactory clinical response. And the combination regimen significantly reduced the risk of this endpoint with a hazard ratio of 0.5. In the most severe patients who present with a high risk of death, or in patients with intermediate risk with severe hemodynamic impairments, initial triple therapy, including an ERA, PDE5, and an IV or sub-Q prostacyclin analog is generally considered. And evidence for this approach is limited, but there is consensus that this strategy has the highest likelihood of success. In terms of follow-up, there's nuance to it, and the algorithm leaves a little bit open for interpretation and physician decision, and a lot's going to depend on patient preference, drug tolerability, and insurance often. But in patients who remain at a intermediate low risk despite receiving dual therapy, you can add a prostacyclin receptor agonist, or you could switch them from sildenafil to riociguat. Finally, in patients who transition to intermediate high risk or high risk despite receiving oral therapies, initiation of IV or sub-Q therapy should definitely be considered. Now, I want to briefly discuss the benefits of upfront triple therapy because I think there's been some evolution in the field towards pursuing a more aggressive initial approach, maybe despite the guidelines. For instance, when you have a young patient with technically intermediate risk disease sitting in front of you, the challenge you have is keeping this person alive and, equally important, active for as long as possible. So you're going to want to do everything that you can do to achieve that, obviously without causing them harm. And here you see a depiction of the added value of sequential addition of medications to decrease PVR with triple therapy, not unexpectedly leading to the greatest reduction in this resistance. And in this graph, you see that nice depiction of the relationship between the decrease of PVR and the likelihood of RV reverse remodeling. And you notice a rapid improvement in the RV when the PVR is decreased by more than 50%, which often you need 3 medications to achieve. And this is from what was a very powerful retrospective analysis of the French PAH registry, which included over 1,600 patients who mostly had idiopathic, heritable, or anorexogen-induced PAH, but it evaluated the association between long-term survival and the initial treatment strategy. And as you can see in this Kaplan-Meier plot, overall survival was highest in the triple combination therapy group. And this was despite greater disease severity being present in this group of patients. So I think these findings support the importance of targeting the 3 pathways of endothelial dysfunction together, which perhaps may prevent the upregulation of one of the other pathways, but really drives home the point that we should be treating our patients aggressively and early. It also brings up the question of whether we should potentially be treating more patients or a higher proportion of our patients with triple therapy, or will this very paradigm be shifting over the next couple of years with the advent of new medications? So our paradigm to date has really been a risk stratified approach to treatment, using dual upfront therapy in the absence of cardiopulmonary risk factors, and sometimes triple upfront therapy in patients at high risk of death. Always stepping up therapy, meaning adding additional therapies or increasing the dose of therapy, and almost never stepping down or de-escalating therapy unless patients develop comorbidities or experience side effects related to the drugs. And when patients have failed triple therapy, their only option has really been lung transplant, in addition to other approaches like palliative atrial septostomies, experimental devices, and of course, clinical trials. So at this point, I'm going to shift the focus of the talk to novel therapeutic targets, which I think is going to be the future of PAH care. And when I've spoken or had the honor of speaking with newly diagnosed patients, what I've stressed is that the way they treat them, or the way that we treat them today, will not be the way that they're treated in 2, 5, 10, and hopefully more than 10 years from now. And here you can see the diversity of potential pathways being explored as therapeutic targets. For instance, tyrosine kinase inhibitors have been explored in response to the understanding that dysregulated growth factors are involved in the abnormal proliferation of pulmonary endothelial and smooth muscle cells. And phase 2 trials of inhaled seralutinib were released this summer and show that this medication excitingly led to the reduction in PVR and increased in PA compliance in conjunction with a reduction in proBNP. Additional therapies that have been studied include those targeting metabolism like metformin, sex hormones like tamoxifen, and the serotonin pathway, to name a few. All of this is super exciting, and today I'm just going to scratch the surface of this with a deeper dive into the most recently introduced drug with a novel mechanism, which is called sotatercept. So first, TGF-beta superfamily signaling has really emerged as a central actor in PAH pathogenesis. And there's growing preclinical and clinical evidence indicating that a major molecular defect in PAH involves an imbalance between the transforming growth factor beta activin proteins and BMP growth differentiating factor proteins, where there's a shift in favor towards activin signaling, causing a SMAD2/3 mediated transcriptional response, and impaired BMP SMAD158 signal transduction, together leading to endothelial cell dysfunction, vascular smooth muscle cell depolarization, apoptosis resistance, and vessel constriction. This is an illustration of this abnormal signaling in PAH, where BMPR2 SMAD158 pathway downregulation leads to the overproduction of activin ligands, which contributes to activin receptor type 2 SMAD2/3 pathway upregulation. Increased phosphorylated SMAD2/3 activity promotes expression of endogenous BMP antagonists, gremlin and noggin, which further reduce BMP signaling. The overall result is a shift in the balance towards the pro-proliferative activin type 2/3 signaling, which leads to pulmonary vascular remodeling. And I like this diagram because it suggests that if you can somehow rebalance these two pathways, that you may actually be able to achieve reverse remodeling of the pulmonary arteries, which has really been the holy grail of the field. Because while we have been vasodilating and probably remodeling the vessels as a secondary mechanism, we haven't been primarily reversing the proliferative processes themselves. So sotatercept is a novel first-in-class activin signaling inhibitor, and it's the first biologic to target this pathway. It's composed of the extracellular domain of the human activin receptor type 2A fused to the Fc domain of the human IgG1, and it acts as a ligand trap for members of the TGF-beta superfamily to restore the balance between the growth-promoting activin pathway and the growth-inhibiting BMP pathway. Of note, it's previously been used to treat patients with hematologic disorders and in patients with conditions characterized by dysfunctional TGF-beta superfamily signaling, including bone loss, chemo-related anemia, multiple myeloma, and myelodysplastic syndromes, as it's known to aid in the restoration of normal red blood cell maturation and osteoblast maturation. And while we don't yet have direct clinical evidence, animal studies suggest that sotatercept inhibits cellular proliferation, promotes apoptosis, and alleviates inflammation in pulmonary vessel walls, perhaps leading to reverse remodeling of the pulmonary vessels themselves. So this was the phase 2 trial for sotatercept called Pulsar. It was a multi-center RCT conducted over 24 weeks in patients with PAH, excluding those with schistosomiasis, HIV, and portopulmonary hypertension. And these patients had functional 2 and 3 class symptoms, and they were all on stable background therapy. So notably, 57% of patients were on triple therapy during the test, and 34% were on dual therapy. So it was a fairly sick patient population. 2 different doses of sotatercept were used, a lower and a higher dose, and it was delivered as a sub-Q injection every 21 days. The primary endpoint was a change in baseline to week 24 in pulmonary vascular resistance. And here you can see that both doses led to significant decreases in PVR of around 2 Woods units and 3 Woods units, respectively. A finding that was consistent across a range of pre-specified subgroups, including patients on IV and sub-Q prostacyclins. The key secondary endpoint was change in the 6-minute walk distance, and sotatercept was shown here to increase exercise capacity and also to improve NT-proBNP levels. The most commonly reported adverse effects were thrombocytopenia and an increase in hemoglobin in both groups of medication, which we'll discuss later. In the open label extension, which went from 18 to 24 months, patients who completed the placebo control trial period were re-randomized to either the lower high dose sotatercept group, and sotatercept participants were continued on their same dose. The main primary objective was evaluating longer-term safety and tolerability of sotatercept, a goal which it met, and the main side effects were epistaxis, increased hemoglobin, thrombocytopenia, and the development of telangiectasias in around 10 to 20% of patients. The primary efficacy endpoint was change in PVR, and secondary endpoints were the 6-minute walk distance, improvements in functional class, and NT-proBNP. And all of these patients maintained, I think importantly, maintained improvements in their PVR, the 6-minute walk, and the proBNP. I think the most notable effect, one of the most notable findings from this study is that 90% of patients at the end of the study were classified as either functional class 1 or 2. And then finally, the phase 3 trial. This was multinational double-blind RCT to evaluate the safety and efficacy of sotatercept in adults with functional class 2 or 3 symptoms on stable background therapy. So it's very similar in study design to the Pulsar trial. These were mostly young female patients with idiopathic and heritable PAH. I think of note, connective tissue disease was underrepresented, which is important because these patients sometimes don't respond as well to treatment in general. And these patients had an average of about 9 years, plus or minus 7 years since their diagnosis. They were assigned to sotatercept, a single dose now, or placebo injected every 21 days. And the primary endpoint of this trial was change in the 6-minute walk distance. And here you can see in the top left hand of the screen that the median change in the 6-minute walk test was significantly greater in the sotatercept group, with a change of around 40 meters from baseline. Improvements were also observed in PVR, functional class, and NT-proBNP level. And I'll say again that here too, the benefit of sotatercept on the 6-minute walk was observed across most specified subgroups, including those on IV or sub-Q prostacyclin therapies, which was previously the maximum available therapy for patients. And finally, of interest is the Kaplan-Meier curve on the right, showing that the probability of event-free survival was significantly higher in the sotatercept group, but the study wasn't powered for mortality. So I want to highlight some of the major side effects of sotatercept, which included the following and will be important when thinking about patient selection for the medication. So adverse events included an increase in hemoglobin level, the development of telangiectasias, thrombocytopenia, bleeding, and a slight increase in blood pressure. Regarding the increase in hemoglobin, this effect was similar to the erythropoietic effects of sotatercept that was seen in previous clinical trials for other diseases. But I think this is interesting because it has led some to question whether the functional improvement seen with sotatercept is at least in part driven by an improvement in oxygen delivery. And then regarding the telangiectasias, this occurred in around 10% of patients and will pose particular challenges for our patients with systemic sclerosis related PAH, for example, who may be prone or more prone to GI bleeding in the setting of underlying gastrointestinal angiectasias that they may have at baseline. But importantly, this neovascularization also suggests that there are likely downstream effects of sotatercept related to changes in underlying vasoactive actors and blood vessel development, which ultimately may prove to be an issue with longer-term use of the medication and adds to the excitement about similar medications with more specific targets coming down the pipeline. So going back to a graphic we saw before, I think you see here nicely that the addition of sotatercept to triple combinations of drugs can even further decrease PVR, with the outcome being favorable relief of RV afterload. A yet unanswered question is whether the histologic changes that we see illustrated on the top of the screen, so here you see the pathognomonic plexiform lesion of PAH, if we're really remodeling these vessels to the nice patent vessel you see at the bottom of the screen, and whether the drug is modifying the disease pathology itself. We don't have histologic evidence in humans yet. With that said, there does seem to be evidence that the use of sotatercept is leading to improved RV function and remodeling. This is from a post hoc exploratory analysis of the STELLAR trial. To orient you, these graphs show the least square mean changes from baseline to week 24 in echocardiographic parameters in adults treated with sotatercept. So for instance, you see that there's improvement in the TAPC to SPAP ratio, which is a non-invasive measure of RV-PA coupling, RV afterload, and load-dependent contractility. And there was also significant decline in RV size and improvement in tricuspid regurgitation, which reflects a lower RV volume load and perhaps also improved coupling. The post hoc analysis also looked at right heart cath parameters. The aspect of these images I would like to highlight is the significant decrease in mean pulmonary artery pressure of around 14 millimeters of mercury with sotatercept versus placebo. This decrease in mean PA was uniquely responsible for reducing the PVR seen with sotatercept, given that the treatment was not actually associated with changes in cardiac output. This distinguishes sotatercept from other currently approved PAH medications, which we have discussed before cause a decrease in PVR by increasing cardiac output and pulmonary flow and only modestly decreasing mean pulmonary artery pressure. With other medications, this decrease in cardiac output is probably related in part to their systemic vasodilatory effects. With sotatercept, though, we see that systemic blood pressure or systolic blood pressure and SVR actually increase, indicating that there may be some systemic vasoconstriction occurring with this medication. And I have mentioned before, since mean pulmonary artery pressure is not a particularly strong determinant of survival in PAH, an important question this raises is whether reductions in PVR, regardless of the means by which it is achieved, are of equal significance. I think perhaps a more important question, though, is does this reduction in resistance and pressure without changes in pulmonary blood flow indicate that reverse remodeling as a primary mechanism is occurring in the pulmonary microvasculature with this medication? And I think there is at least the impression that it may. And so coming back to this illustration, I guess I think a better question than whether sotatercept is a disease-modifying drug is whether it's moving the needle to the right, closer to a cure, and in the process ensuring better clinically meaningful outcomes for our patients. So far, the answer to that question seems yes. And I do want to mention here that there are other activin inhibitors in development right now, both that I'm aware of are activin receptor type 2B ligand traps, so they have different binding profiles than sotatercept, and thus may have different side effect profiles and enhanced tolerability, but that's yet to be seen. So I hope I've convinced you of a few things. One, that our classic PAH medications do a great job at providing a foundation of therapy that has a primary mechanism of reducing PVR to drive reverse remodeling of the right ventricle. And these therapies probably have additional mechanisms that work more directly on the pulmonary vasculature itself. Two, that new medications like sotatercept will have novel mechanisms that likely work more directly on remodeling of the pulmonary vasculature. And three, that the impact of synergy between these medications is going to revolutionize the state of treatment for patients. But now the question is, where do we go from here? And if you're a patient with PAH, you're definitely curious and excited about this medication that has gotten so much hype. You've seen it on TikTok, you've read about it on Facebook, and you're especially excited about the fact that it can be injected at home once every 3 weeks. So that starts to sound a little bit better than being on a continuous IV infusion. And I think what patients and physicians alike are wondering is whether medications like sotatercept will allow for the de-escalation or the replacement of IV and sub-Q prostacyclin analog therapy, thereby altering our previous paradigm of treatment of PAH. So where does sotatercept fit into our treatment algorithm? I think based on the trial population at this point, it definitely is reasonable to consider adding sotatercept onto patients who remain intermediate or high risk despite treatment with dual or triple therapy. But there are ongoing questions about whether it should be added prior to prostacyclin analogs or even instead of prostacyclin analogs. And taking it a step further, and this is moving beyond a trial population, should we be thinking of adding it on as initial triple therapy in the originally dual therapy group, or even as quadruple therapy in the previous triple therapy group? And then obviously once patients are on sotatercept, will it be possible to start tapering them off some of their other medications? I think ultimately time and experience with this drug will help us build new practice patterns. But again, this is only the first of a number of new therapies that I'm sure are going to appear within the next few years. And so this algorithm is going to continue to evolve. So again, what we're doing today won't be what we're doing, I'm sure, in 5 years from now. So back to our patient. At the time of the right heart cath that I showed you before was just about the time that sotatercept was starting to be used in our clinic. And she was prescribed sotatercept, and she was one of the first patients in the clinic to start this medication. She was referred for lung transplantation at the same time, given we weren't sure how she was going to respond to treatment, and we remained very concerned about her worsening hemodynamics. And she just underwent a repeat right heart cath last week. This is 11 weeks after she initiated sotatercept. As you can see on the right half of the screen, she had significant improvement in her mean PA pressure, now 48 from 67 previously, and an improvement in her PVR from 12 to about 8, with, I would say, overall stability more or less in her cardiac output and cardiac index, similar to what we saw in the trial population. So the numbers are certainly impressive, but it's not clear yet if she's had meaningful clinical improvement in her symptoms, which is really the more important thing in my opinion. So in summary, PH is a disease primarily affecting the pulmonary vasculature and the right heart, and it carries high morbidity and mortality. The current treatment paradigm involves a systemic approach to medication selections and symptom management with an aim of maintaining a low risk of mortality. And recent advances in our understanding of disease mechanism is leading to increased treatment options for patients that will ideally provide meaningful improvements in outcomes and quality of life for patients. And so sotatercept is the first to market, but there are more to come. And as the field continues to develop new medications, I expect we'll see an increase in the therapeutic index of these therapies through a refining of treatment targets that optimize the clinical benefit and enhance tolerability for our patients. So with that, I would like to thank you, especially to my mentors, Dr. Joseph and Dr. Singh, but really to the whole pulmonary vascular team who's taught me everything I know, including Corellis, Jennifer, Lindsay, Diana, Ashley, Anna, all of the respiratory therapists, and of course to my co-fellows. Thank you.
Okay, thank you, Dr. Tarras, for that excellent talk. And we'll take questions from the audience. Dr. Siegel.
Elizabeth, that was really spectacular, clear, comprehensive. Felt like I had a free ticket to ATS today, so thank you. You said at the outset of your talk that this is pulmonary hypertension is a rare disease, and the diagnosis is delayed often. And I'm curious, as you've started to see more and more fresh patients, what you've learned about the reason for the delay. Is it just because it's rare, or are there other things that we should be thinking about? Because a lot of what I concluded from your talk is that the faster you can start treating somebody, the more likely they'll do well in the long term and short term as well.
I think that's a great question. And yeah, I mean, early diagnosis is pivotal to improving outcomes, especially survival for these patients. And I think that, one, we have to have a really high index of suspicion for PH in these patients. And that's difficult because symptoms are often really subtle and often nonspecific. So patients are presenting with dyspnea that's usually been worked up by multiple tests that don't reveal a clear cause of the symptoms. And so you need to have a physician or other medical provider that's going to kind of keep working to find an answer for you in the face of what seem objectively like normal data. So I think one, that index of suspicion. Two, I have to say most of our patients are female patients, and we know, and there's data showing that these patients' complaints are written off. So I think it's not surprising to me that most patients are female and that their disease is overlooked and that there's a delay in their diagnosis. So I think in the past couple of years of medicine, we've seen just like a greater reflection and introspection into that idea, and hopefully more awareness on the side of providers to kind of check their biases.
As Mark Siegel said, just an absolutely superb presentation. First is a question, the second is a question/comment. Why is the average age for these patients going up to over 50, number one? And number two, it seems to me if it is disease modifying, this drug, sotatercept, how about starting it, as you suggested, as early as possible when there's a chance to prevent progression? And do you see that as to where we're going?
So your first question, I'm not certain of the answer. I think a lot of it has to do with the increased awareness of the disease. So I think probably more people are diagnosed because more people are looking for the disease. Two, I think it probably has to do with the comorbidities of the patient and how those comorbidities are related to the development of PAH. We see a lot of patients with what we call atypical PAH in an older population. So while their hemodynamics may look like typical PAH hemodynamics, where you have an elevated mean PA pressure, an elevated PR, and a normal wedge pressure, they have underlying risk for left heart disease, including hypertension, atrial fibrillation, obesity, et cetera. So while they may look like a typical idiopathic PAH patient, they're really, they probably have a mixed phenotype that's not reflected clearly in their hemodynamics. That's the first question. The second question, I mean, that's the big question. So I think, and that's where all of the excitement about the medication exists. So I think right now we have the trial, and that's going to be guiding how people initially prescribe the medication, like all new medications. And then because people are thinking about this very question, they're going to start getting creative and prescribing it in other patients, and more trials will happen, particularly in patients with functional class 1 and 2 symptoms, and we'll wait and see. But it's not, I guess I'll say, like, the medication has side effects, has a side effect profile, and so you also don't want to do harm when starting a medication when it's not totally benign to do so, even though it seems like a good idea.
And Dr. Matha, I think for your first question, my theory, or I think there's increasing data about this, is that the Western diet and obesity epidemic is probably contributing to the age drift. If you look at the female paradox, females develop worse pulmonary hypertension, likely due to underlying hormonal differences between males and females. And then with obesity and adipose tissue, there's more estrogen in male patients. So I think that's also contributing to this new development.
Thanks. Thanks, Elizabeth. That was a great talk. Yeah, just piggybacking off of Mark and Richard's question, because there's a lag time in diagnosis, how do we actually know disease onset to really know if we're actually impacting it? Do you see what I'm asking, right? Like, we don't really know, right? If people have symptoms for so long, do we count the start of their disease at the time of diagnosis or the time of symptom?
I guess the question is,
right? Like, I don't,
Yeah.
you don't have to have an answer.
I mean,
but I'm just raising the idea, right? Like, have they thought about that in these trials, right? Because it's a tricky thing. It's not like, okay, because there's, like you said, there's such a long lag time. People have symptoms for a long time, right? Does that make a difference in how we look at our outcomes if we decide that onset of disease was beginning of symptoms versus time of diagnosis?
Yeah, I think it's a really good question. And I think there's a difference between how you think about it in clinic and how people are thinking about it in clinical trial development. In clinic, you're going to kind of think about that when you see a patient and they tell you they've had symptoms for 4 years and they've gone to 1 million doctors, and now you diagnose them with severe pulmonary hypertension. You're thinking, okay, they've had this disease for a long time. You have some maybe objective markers of how severe their disease is based on their vasoreactivity testing. And I'll let maybe Dr. Joseph comment on this as well, but you wonder, in a patient who's had symptoms for a long time, who has very little pulmonary vasoreactivity, have they had such severe remodeling over a long period of time? And is that reflected in the hemodynamics that you're getting on right heart cath? But none of this, I think, has been proven.
And so nobody's looked at this new drug yet, just as a first drug.
No, yeah, so I said nobody's looked at this as a first drug, just as an add-on. And I think that's been an issue with PAH trials over the past 15 years in initial trials in the 90s and the early 2000s, they were able to study these drugs against otherwise standard of care. So like the first epoprostenol trials were, the placebo group was in patients who were just receiving diuretics and anticoagulation, et cetera. But in the age where the standard of care is receiving multiple therapies, it's going to be impossible to do these trials now. It is impossible to do these trials in large groups of people head to head against a placebo, not on any therapy.
Yeah, Dr. Prasanni, I think for example, for the fellows lecture last or 2 weeks ago, I presented a case. A 20-year-old varsity soccer player presents with dyspnea or dyspnea at the peak of her Peloton ride. And should that be taken seriously? And I say, yes, it should be. She's waiting 6 months to see me in clinic, and she's complaining of dyspnea at the peak of her Peloton ride. And she ends up having exercise pulmonary hypertension, diagnosed with an invasive CPAP. But I think that's probably the struggle here, which is if that gets presented to your primary care physician, which is no insult to the primary care physician, what do you do with that? It doesn't sound as serious.
Hi, piggybacking on that, I think there's also a problem with maybe overdiagnosing it, right? Well, people have some echo findings, and then you really have to do a diligent job to figure out the left heart disease. I've seen several patients who had been started on PA-specific therapy and turned out to have not diagnosed left heart disease at the time. It did do very poorly. Follow-up question on that. In some forms of left heart disease, we do see these plexiform lesions, for example, congenital heart diseases and so forth. So if you want to speculate, could this drug play a role in pulmonary hypertension triggered by left heart disease?
Well, say it's being studied right now for sure. There's ongoing studies looking at patients with combined pre and post capillary pulmonary hypertension or combines left and right heart disease. So I think people are definitely interested in it because the pathophysiology of left heart disease related PH also involves significant vessel remodeling, though perhaps more so in the post capillary venous circulation. So I think people are certainly interested in it, even though traditional pulmonary vasodilators haven't really been shown to be helpful in that population for the most part. Regarding your first question about, I think I understood it, maybe the risk of overdiagnosis of patients. And I think that comes up, especially when we diagnose exercise PH using invasive cardiopulmonary exercise testing, and you have patients with very mild hemodynamic abnormalities. The question is, what do you do with them? Do you treat them? And we know that these drugs haven't been studied in that patient population. And from clinical experience, we know that patients often don't tolerate these medications as well as patients with more severe hemodynamics. But I think the question you have to ask yourself is, what is this patient's risk of progressing? And if the patient has underlying risk factors for developing significant progression of disease, especially like connective tissue disease, then maybe it's not mild PH, but it's just early PH. And so I think you just have to find the right patient population, feel comfortable treating them, and then also feel comfortable de-escalating therapies if they don't tolerate that medication. So that's what's important about having these patients go to a PH center where there's the infrastructure to support following up with those patients well and regularly.
And just to add to that, so we do have a clinical trial ongoing, the Cadence trial, looking at sotatercept in combined pre and post capillary pulmonary hypertension. And then going along to your first point, overdiagnosis, I think it's a real thing, which is, I think it's important to, I think we have to rethink how we phenotype these patients in the cath lab. And that, like Elizabeth mentioned during her presentation, that a wedge of 15 is not technically normal. It should be 12 based on normative data. And that if you see a wedge pressure of 12 to 15, that to me signifies that there might be atypical PAH or underlying diastolic dysfunction and might lead to intolerance of pulmonary vasodilators. That was shown in a follow-up study to the AMBITION trial, the upfront combination therapy trial that people who had atypical PAH ended up being weaned off one of their pulmonary vasodilators. And I think what I'm kind of evolving in how I perform right heart catheterizations is being cognizant of that, of those wedge pressures, and should I do a fluid challenge at the end of a case with nitric oxide, or give nipride with nitric oxide to reduce systemic afterload. I mean, it's going to be like a 2.5 hour right heart cath, but I think that's maybe where the field is going. Dr. Siegel.
So I thought one of the most provocative parts of your talk was when you're showing the different hemodynamic responses to the different medications. And particularly with sotatercept, it's really interesting that the PVR drops, but the cardiac output doesn't rise. And, part of me was wondering, well, that's really counterintuitive, right? If you've got a failing RV and you decrease afterload, why doesn't it rise? And maybe there's some signal in there that I wonder if you've thought about what that all means. So for example, I can imagine that not raising the cardiac output might protect the vessels in some way, right? Because they're just not being, getting like barotrauma, or maybe, and I'm curious, like what happens to why doesn't the cardiac output go up? Is the stroke volume not rising or the heart rate not changing? Because it seems to me that would matter.
Yeah, and I think that's a good question. I didn't include this data, but the post hoc analysis of the STELLAR trial did look at left heart hemodynamics as well. And they presented some nice data, kind of trying to elucidate why the cardiac output wasn't going up. But some people posit that the afterload is increasing, so that there is increased systemic vascular resistance with sotatercept, and so the increase in afterload perhaps is related to the lack of increase in cardiac output. There's some question about whether it causes some like myocardial cell depression. I think it's still too early to tell, and I don't have the data in front of me, but I will share the trial with you, because they go over some of the impacts on the left heart, which I think probably are at least in part to blame for the lack of rise in cardiac output.
Okay. I think we're done for today. Thank you for attending. Good luck, Tarras.